Hello, everyone, and welcome to In Service of Health, brought to you by the Public Health Accreditation Board, FAB. In this episode, I sit down with Dr. Kameron Matthews. Dr. Matthews is a family practice physician, she's a lawyer, and has really had an incredible career as a physician executive in correctional health, in the VA health system, working in FQHCs and Cityblock Health, a startup. We talk about what high quality primary care means, how public health and primary care can really work together, and what does it really mean to have a supported workforce that can meaningfully improve community health outcomes. I hope you enjoy this episode with Dr. Matthews. Dr. Matthews, thank you so much for joining us on In Service of Health. So happy to have you here.
Oh, I'm excited to be here. Thanks for having me.
Yeah, so let's jump right in. Can you start by, you just have this phenomenal career. Start by telling us a little bit about your origin story and specifically what motivates you to do this work.
Yeah, so um, let's see. I try to tell my origin story different every time to challenge myself.
I'm
So let me
I'm
do
here for it. I'm here for it.
that. No, you know what? I was very much interested, actually, I think before we had concepts of social determinants of health and like the business of health and all of these different pieces that physicians are really kind of driven into that we're starting to kind of
Yep.
diversify our leadership expertise in our ownership of in our different spaces. I knew I wanted to do a little bit more than just clinical medicine. So in undergrad, I majored in public policy. I ended up being very easily steered by a mentor to go to law school. But all of this still in an interest in, at that time I said medicine. Now I realize it's broader
Yeah.
healthcare, right? And
Yep.
so, that is also something that's been refined over time in my own head, as well as I think within the medical space. But um, yeah, I always wanted to be a primary care physician, very
Yeah.
proudly a second generation family doc, but wanted to try to approach solutions from a broader policy perspective. So I apologize. I thought it was going to be a degree in public health, but then the law degree ended up
That's great.
being a really good option for me. But I think it's all in the same vein. It doesn't matter what you study in a classroom setting. It's really about, how can we make, broader strides towards solutions for our communities. And so with that, I knew it wasn't just going to be in traditional care
Yeah.
delivery. It definitively was not going to be an academic medical center sort of environment. So all of my roles have been in some level of an underserved community. So
Yeah.
starting in correctional medicine, federally qualified health centers, Veterans Health Administration, and of course now Cityblock, where we're focused on Medicaid and dually eligible populations. Really those that need us the most and that are unfortunately not navigated as well as perhaps some of the members of our community who have commercial or Medicare options. So uh, yeah, my story is one of wanting to find solutions, but then also broadening my exposure, my
Yep.
experiences, so that I can hopefully try to integrate all those different pieces.
I love that, and we've had time to chat before. You're just such an inspiration to so many folks, and you've been in so many different professional settings. But this podcast is really about kind of that intersection between healthcare, as you talked about, and public health. And we have a broad, swath of folks who are listening to the podcast now. From some are physicians, some may be nurses, some work in public health and have various degrees. Tell us, why is public health in particular important to you, and why is it, or should it be perhaps, important to society?
Yeah. And I may fumble this answer because in my mind, I actually have problems separating
Hmm.
kind of my own calling in primary care from public health. I went into primary care to help prevent disease and promote well-being, and to do so now I realize at a population level, right? And so for me, how we think about public health is more of an organized effort for us in medicine, but broader than medicine. All of us having ownership over how we support our communities, how we really invest in prevention and education, how we think about disease as, I would say, stripped of the kind of morality attached to it, and we really want to approach our patients, our communities, from a sense of empowerment. And for me, that's what primary care is. That's what public
Yep.
health is as well. So again, I have difficulty separating the two. I feel like what I do in primary care is public health and vice versa. I actually think a great deal of what you do in public health is primary care, and it's what we need to do, perhaps at a different scale, but it's what we need to do, especially in the communication space, in the promotion of preventive screening services, of staying away from substance abuse and other kind of harmful experiences and substances and the like. I think all of that is, again, what we are doing and unfortunately may not have the time to do in the primary care space. So it's
Right.
hard for me to separate the two.
Right. And I don't think you botched that answer at all. I think it's, I'm a ER doc. I worked in public health and, worked in corporate America. And I actually think it's probably not doing our country any good. It's a disservice to force ourselves to separate. And dare I say, even sometimes feel like different fields are competing with each
Yes.
other. And
Yes.
we can talk about, how healthcare is funded in this country, but it actually seems like countries who do this well and have better health outcomes, they don't actually separate healthcare and public health.
That's
Um, so,
exactly
so,
my point.
yeah,
There are
exactly,
examples of not separating the two and that are
exactly.
successful. Exactly.
Exactly, exactly. But let's lean into primary care
Hmm.
because you are definitely an expert in this space. You talked about some of your leadership roles, FQHCs, correctional, health, the VA, a successful startup. But you also were a very important contributor to a National Academies of Medicine consensus study, I think it was in 2021, which really leaned into implementing high quality primary care across the United States. So I wanted to talk about, because I have you on, some of these concepts in that report, which I think are really important. Um, the first one is really, in the beginning of the report, it talks about the trajectory of primary care in America. And maybe we can touch on what we just talked about, which is like, why is it so separate? Like, why is it funded this way? So talk to us a little bit about your views on primary care in general. What have we done well in this
Yeah.
country, and where are we failing and need to do better?
Yeah. I really believe that primary care should be, it's definitely not, but should be the chassis of the healthcare system, the healthcare delivery system. I think the principles that Barbara Starfield promoted around what primary care is, meaning we coordinate care, we provide comprehensive care, we are the first contact, and of course that's
Yep.
shifted and oftentimes to emergency medicine. But we also provide continuity of relationships so that you have a doctor and you have that usual source for trust and just ongoing relationship. I think all of that is really fundamental, again, to us improving health outcomes. And I say I think there's actual evidence behind
Hmm.
this, and we pulled that together in the 2021 report. It was also very much present in the 2016 report. We've done this multiple different times now, where we've summarized really the impact on chronic disease, on disease prevention, actually, through primary care. And the fact that that's not the chassis of really our healthcare system now, I think is one of the reasons why we're struggling. We are, as everyone loves to call it, we're a reactive system, we're a sick care system, all of these different phrases that hit the media and the like. It's because we haven't invested in the real strength behind what a primary care system is, where there's
Hmm.
accountability in that continuity relationship, where we're responsible for outcomes in a bigger sense than just managing an inpatient admission or looking
Hmm.
at encounters of care, but we're responsible for the longitudinal relationship that's there.
Right.
Um, for me, primary care is a solution to a lot of the ills that face us. But upstream of that, we obviously need to think about the business models that don't allow us to build that primary care structure in the same way that we
Yeah.
don't have the business models or government support to build out public health infrastructure, right? It's the same sort of piece that we have evidence behind the strength of the different solutions through public health, through primary care. We just haven't facilitated it because of the business model that the tertiary healthcare system
Yeah.
unfortunately forces us to respond to.
Yeah. So let's dig into that a little more. I'm going to make this a little bit personal. So I'm a doctor. You would think I'm a
Yes.
doctor, so I can I know doctors. I can access my own health care. But I'll
Mhm.
tell you what challenges me with primary care is I have a primary care doc who's assigned to me. Last year, and it's twice a year, once a year, whatever it is. I'm relatively healthy. I don't go that often, thank goodness. But my primary care physician was out, whatever, they had to cancel my appointment. And the next available was like 6 months later.
Mhm.
And then they automatically assigned me, and I couldn't actually, I was going to be out of town, whatever it was, I couldn't make that appointment. So it ended up being like 2 years for me to not be able to, see my primary care. Now, I'm not blaming the primary care. You know exactly why that happened. So
Oh
what is the challenge? Why is it that my primary
yeah.
care doc, got canceled and I can't get to one, and I've got commercial insurance, right?
Yeah.
So
Yeah.
tell me a little bit about what's happening behind the scenes there.
This is where we emphasize the concept of high quality primary care, and not due to the intent of your PCP, of the hundreds of thousands across the country that are doing this hard work on a daily basis, but when they're forced into 15-minute appointments, when they're forced into thinking about encounter-based approaches as opposed to, again, that continuity and that comprehensiveness that primary care should allow, that otherwise changes the way they deliver the care. In the same way that, I hate to say this, the payment models change the way the rest of the healthcare delivery system changes. Every other specialty faces this as well. You start to focus on what's bringing in revenue.
Mm-hmm.
And we in primary care, unfortunately, are burdened not only with shortened opportunity for relationships, bigger and bigger panels every year in order to make sure we support those revenue drivers. Focus on risk adjustment over here, quality metrics over here that are very more process based as opposed to outcome based.
Mm-hmm.
We're not, unfortunately, in the limited space that we have, and I hate to say that about your own PCP, in that limited space that they have to connect with you, they don't have the ability to achieve the highest quality
Mm-hmm.
possible.
Mm-hmm.
And so it's not just about increasing the amount of time in an individual visit. It's also about changing the incentives around the business model of how we move from more of I don't believe that primary care can be judged in an encounter based structure, and that's what we're forced to face in the overwhelming majority of cases. Medicare Advantage, some other value based plans are taking us in a different direction, right? But when it's really about just your visit and there's not really any sort of value and therefore payment on that asynchronous between visit care, they otherwise are doing you a disservice and aren't providing the highest quality that they can. So perhaps you don't need to see your primary care doc every two
Right.
years. That's the whole point.
Right.
You
Right.
don't
Right.
necessarily need to see them, but you need to connect. You need to share information. You need to be able to maintain that relationship. And there should be multiple different forms in which we can do so. But again, the business model doesn't recognize those. A little bit in telehealth, yes, but it's still encounter based. It's just
Right.
on a different modality.
Thank you. Thank you. And I also, I love this concept of primary care being a common good that is also kind
Mm,
of brought up in this report. Tell us more, elaborate more on what that means for
yeah.
primary care to be a common good and public health also being a common
The
good.
common good. Yeah, I think it goes back to the larger concept that healthcare is a right, and that to be able to engage with the system, to be able to learn about your own healthcare, to be empowered, to be able to manage on your own, perhaps your prevention, but also your chronic disease, should
Mhm.
you progress into that. That is really a broader, I would say, responsibility of society. That's what a common good is. It's a responsibility that, regardless of whether this is not an argument around single payer system or the government sponsoring it or the like, but it is the responsibility of society. I believe the report believes that all members of society are able to have these services, and that we're able to do so in an equitable fashion. So it's not just about providing access in a network, but it's also about empowering our patients upstream to actually then utilize that network, which is one thing we often forget when we tend to de-emphasize how we in the healthcare system can assist with social determinants of health. So it's a common good because we believe that all members of our society should be able to achieve their highest capability of health and well-being.
Yeah, I love that. Let's talk a bit about how can public health and healthcare work together, and even maybe getting tangible. You've got I talked about my primary care office. I don't know what they're doing in the community. I remember when I was leading Michigan's COVID response, we had to get vaccines out, and like my primary care office for my kids was actually calling me because they knew who I was, and I was literally myself trying to help them get vaccines out. Tell us more about what does it look like for
Oh my
primary
goodness.
care and public health to work together and work together well.
Every environment that I've practiced in, that I've helped lead, is leaning into public health. I think it's very hard in smaller private practices, I
Yeah,
admit, because
yeah.
they're trying to keep their doors open. Margins are minimal, if not negative at best. But in the environments that I have practiced in, majority of which have been government sponsored, right?
Hmm.
In the correctional setting, for instance, we were doing 100% screening for STDs and HIV
Hmm.
and hepatitis, and we
Hmm.
were treating accordingly, so
Hmm.
that as those members of society then transition back into their communities, we're preventing spread. We're also educating them and hopefully allowing them to educate their family members.
Hmm.
In the FQHC setting, we hold community fairs. We reach out to different organizations. In fact, Mile Square, where I was CMO for several years in Chicago, we met with the First Ladies Organization of the churches in Chicago and started a large campaign around breast cancer screening, so that we could actually educate congregations, educate the women, bring them into our facility where we actually had a mammography capabilities, where we could actually then sponsor afternoons where they were coming in for screening instead of just saying, oh, go talk to your doctor. We could actually
Hmm.
provide those services ourselves. In the VA, public health is rampant because we actually think of ourselves in every way as accountable. Again, I think
Hmm.
accountability keeps coming up in my mind about how we actually think about solving health outcome issues and disparities, more importantly. But in the VA, you are accountable for the whole health
Yeah.
of that veteran. You are concerned about their eating, their food insecurity, if at all. They are in every way concerned about their housing. You are, of course, concerned about their mental health and broader access to services to support any of the vestiges of their service and the like. That in and of itself is embedded throughout the VA health
Yeah.
system and not separated. In fact, we don't even really call it public health. That's part of
Yep.
the broader care that you give to a veteran. And then, of course, in Cityblock, we are doing all that we can to think through opportunities to reach out to the community, to in every way respond to the fact that healthcare is very local. So how are we actually educating not just our members, but the community that surrounds them, the ecosystem that surrounds them, so that we can assure better outcomes across the board?
I just love how you describe all those different examples and this focus on really whole person health. And also something it just reminded me of, I've worked in governmental health departments at the state and local level, but I've always said the work of public health is not just about the work of the governmental health department. The governmental health department, to be clear, is very important, central, helps coordinate, understand data, all of that. And we have to think about this broader ecosystem and how they can all kind of play a role. So I love that. Let's pivot a bit and talk about the workforce.
Yeah.
And this concept of interprofessional teams, some of the data from the National Academies report we've been talking about, 25% of physician assistants, 15% of nurses, 29% of advanced practice registered nurses are working
Yeah.
in primary care settings. And of course, there's physicians, there's community health workers, which is an important part of the
Peer support.
workforce.
Exactly.
So tell us, like, how do these and should these kind of teams, these primary care teams, be working? And what are the different roles and responsibilities?
Yeah. Well, thanks for letting me promote our newest paper. Actually, it's not
Yes.
our newest paper. So I also sit on the standing committee on
Yeah.
primary care, which is really the next step beyond that 2021 report.
Yep.
And I just co-chaired a recent paper on building and sustaining interprofessional primary care workforce.
Yep.
And part of that is really recognizing, as we described, as you described, the shortages, the supply and demand mismatch there of the workforce, and that we really need to approach our workforce issues from a labor economics standpoint.
Mm-hmm.
If we don't pay enough, if we don't pay in the right way, we're not in any way going to not only develop, train, but also sustain a workforce that can provide that high quality care. And what I mean by that, it's not enough to just say there are enough primary care providers, regardless of what that provider role is, that there's enough in a town. You need to make sure that the entire extended care team, and we really do mean extended care team, is just as valued and just as much as integrated into the payment structure and the outcome structure that is necessary, again, to improve those outcomes. So it's about medical assistants, it's about care managers, it's about behavioral health staff and integrating
Mm-hmm.
that into our teams. It's about even clinical pharmacists. It's about community health workers, peer support, health coaches, and the like. It's about even oral health specialists and dentists in some communities, as FQHCs have always done as part of their mandate.
Mm-hmm.
So, in developing the workforce, we need to make sure we build it the right way, which means the training, which means increasing GME support and other training programs. But it's also about making sure that we are maintaining that supply of the workforce, and that means paying them adequately. And we just had a panel a couple of weeks ago where the chief clinical officer for a rural health system in
Mm-hmm.
Virginia spoke at length about how the medical assistant, like that is a critical
Mm-hmm.
piece of the primary care workforce. Again, not just the PCP, but the medical assistant population in their community was being, I hate to say this, poached by the local casino that opened up because the
Mm-hmm.
payment rates to work at a
Yeah,
casino were above and beyond that we were paying our medical assistants. If we value primary care,
that's
if we
right.
value prevention and chronic disease management, we need to maintain the entirety of the care team, the entirety of the workforce. So a lot of the focus just being on the PCP, unfortunately, is not sufficient. We also talk about, though, in the paper, again, it just got released last month, so I hope others go look for it.
Yes.
We also talk about the accountability, therefore, of how we actually drive this. So this is about payers making sure that their contracted networks are actually directing primary care funds into the primary care practices so that
Mm-hmm.
these larger health systems, as they start to vertically integrate, they're not just taking these new primary care, alternative payment models. We've got this new system that was released this year for Medicaid around advanced primary care management, that those funds coming in are not just directed back into the health system to the more revenue driving actual service lines, but that they actually go back into primary care. So, where's the accountability? How are we tracing that? Where are there contractual requirements, even state level regulatory
Mm-hmm.
requirements that health systems actually feed that back into primary care? And then we think there needs to be some tracking at a government level, state
Yeah.
level, local level, so that we understand what the workforce is. Because a lot of the numbers that even describe the supply out there are only describing the potential
Mm-hmm.
population
Mm-hmm.
that can go into primary care. They're actually not measuring who is actually working in primary care. And the burnout factors that we have for primary care physicians are equally present for nurse
Mm-hmm.
practitioners and physician assistants. And the salaries, again, are also driving them into specialty care just as much as our MAs and our nurses. So we have a lot of work to do there,
Yeah,
but we need to
yeah.
think of it from a labor standpoint as opposed to just banking on the argument, just pay for primary care more. Of course, we need to. It's a ridiculously small
Yeah,
component of our healthcare
yeah.
expenditures, but it needs to actually be valued to the point that the workforce actually drives the outcomes that we want.
So many nuggets there. I love what you said about kind of developing training and sustaining the workforce. How do we really fund the primary care system aligned with our values and our priorities? And then this piece about accountability, right? Like it shouldn't be a health system gets dollars and all of a sudden it goes to I won't name any specialties here, but it goes
I'll
to the
name one
more
now.
it goes to the more revenue generating fields, which don't
Exactly.
actually necessarily long term prevent and improve the
There we
broader
go.
health of the community.
Yep.
So that's just so important. So I got to talk about the Public Health Accreditation Board.
Yep.
FAB, we call ourselves fabulous. We are the accrediting body for governmental public health. Over 450 health departments are accredited. Most people in the United States are covered, whether it's at the state or local level, by an accredited health department. And we really, to your point about high quality primary care, we are the organization that advances high quality public health. And so a lot of our listeners are sitting in health departments, state, local, territorial, tribal, right now,
Mhm.
and maybe thinking, okay, I'm a health department, employee, staff. I work in whatever program. I like what they're saying about primary care. I believe in it. What should they do? Whether it's you're working in a health department or quite frankly in a primary care office, like you're going to work tomorrow, what
Mhm.
should you be doing to reach out to public health, governmental health department in particular, or vice versa, to really
Mhm.
move the needle on
Yeah.
important public health priorities?
I am a huge proponent of federally qualified health centers. And I think the very first direction, especially when we're talking about where the most improvement of outcomes needs to be sought, especially when we're talking about the inequities that certain populations face, that's where those patients are actually being seen. About 1 in 7 patients on Medicaid is seen in federally qualified health
Mm-hmm.
centers. So those entities locally really knowing every single FQHC, knowing their leadership, knowing what programs they're actually deploying, like I described the breast cancer screening program in Chicago, knowing that those are occurring, partner on them, not recreating the wheel, sharing
Mm-hmm.
education materials, sharing workforce to actually promote those services, making sure you're really thinking about the scope and the span of geographies that are being reached jointly. I think those relationships are critical. The
Mm-hmm.
public health is a necessary component within the healthcare system, but it's only going to be achieved through that collaboration as opposed to the siloed effort. So, as
Mm-hmm.
you've even
Mm-hmm.
said, thinking about public health and primary care separately is doing us a disservice. So, understanding how these FQHCs are working, what their shortcomings may be, where they actually have strengths as well.
Mm-hmm.
Um, Especially I can think of an example in Chicago, we stood up a behavioral health integration program in our FQHC and hired a wonderful psychiatric nurse practitioner. We're starting to do medication assisted therapy
Yep.
for substance use treatment. I mean, that in and of itself is something of great concern in most of our, actually, I was going to say urban, actually all centers. That has nothing to do with geography. Substance use treatment is necessary everywhere,
Mm-hmm.
and how the public health entities can actually lean in, support those FQHCs, maybe through partnership around monitoring, around maybe boots on the ground in the community so that we can direct patients into these
Mm-hmm.
programs and the like. I think that's where they need to start.
I love that. And something else that I think you're alluding to is this concept of being embedded in a community. Even when you spoke about the medical assistants, I'll bet you, similar to community health workers, a lot of the value is around that lived experience and
My
embedding
goodness.
people in care teams. Tell us more about that importance of lived experience when it comes to primary care and public health.
Ah, evidence is abundant,
Mm-hmm.
and we've definitely been describing this since the unequal treatment report
Mm-hmm.
in the 90s, the 2000. I'm sorry, I forget the
Right.
date. I feel like it came out in 96 maybe. Also from the academies, but
Mm-hmm.
just really understanding honestly the breadth of evidence that the concordance, not just racial, but just experience concordance
Mm-hmm.
between the workforce and the patient population is critical. That's how we earn trust. That's how they believe in our recommendations and seek to adhere to our plans. That's how they actually have retention in coming back and maintaining that continuity in
Yep.
relationships. And that is up and down the care team. Again, it is not just about the PCP.
Yep.
For your medical assistants, your community health workers, all of your staff to be from the community, to understand what the other community-based supports may be, to understand the faith-based community there, to understand the educational environment, and how schools are actually able to or not support children with complex issues and the like. All of that is necessary throughout the workforce. So
Yeah.
that concordance, it's been shown time and time again. We spoke about it in 21. We speak about it again in this recent report, that the workforce needs to be tailored, not just in expertise, but in ability to really engage and earn
That's right.
trust from the community they're serving.
That's right. That trust is so important. And to your point, there's plenty of data around that concordance, whatever that means in that community. That concordance is
Whatever
so
that
important.
means.
That's
Exactly.
right. That's right. So, on a related topic, let's talk about access to care.
Mm.
It's one thing to have insurance. It's one thing for there to be, primary care offices, wherever. But we know that a lot of the U.S. population, in fact, 20% of the U.S. population resides in a health professional shortage area, and about 40% of rural counties in the U.S. are designated as such. So maybe you can talk a little bit about, again, you're an expert in this, what that actually means to be a health professional shortage area, and then what should healthcare leaders be doing now when it comes to access to care for
Mm-hmm.
those who don't have that access so readily available.
Uh, this is what's so difficult in our current environment with the government shutdown. I won't go into any other pieces of what's happening now, but at least with us not being able to really have that continuing resolution to get to a new budget, Medicare unfortunately is going to have limitations around telehealth, as well as hospital at home programs. These sort of, I mean, I don't even want to call them innovative anymore. They are standard of care of how we
Mm,
can actually reach patients, regardless of geography, not just rural, but even in urban, to be able to really right size and right fit what type of services a single patient, a family is able to access. We need to think outside of this ivory tower where we expect patients to come to us. So whether it's through that mobile van, whether it's through home-based services, whether it's through virtual, a significant portion of the care does not require a physical exam. Again, that is very business model based because you need to lay hands to be able to bill at
mhm.
a higher code. We need to be able to recognize that primary care, public health, a lot of it is about conversation, a lot of it is about connection. And while you need that personal, in person, boots on the ground opportunity, yes, to often earn trust, I don't want to deny that in any sort of way. When we're thinking about that specialty care, when we're thinking about the way that we can bring services across the country to those most needy geographies in our highly rural areas. This was a huge area in Virginia, sorry, in the VA. I think VA, and I said Virginia. We need to be able to recognize that we have a lot of services that can be brought by screen, by even AI solutions as we're leaning into them. So I'm happy that both at the VA and the Cityblock we've been able to explore new solutions to be able to open up
Yeah.
that access. So much of that access, though, can just be a conversation.
Yep.
So it's not about that brick and mortar. And in fact, the brick and mortar is often what ends up destroying your margins. Like, so if we can think of different ways to actually get to these patients, in the way that, I hate, we always do this in family medicine, but the way that old school town doc used to knock on the door carrying their black bag, That's really where we're going to need a significant amount of focus. And then as you think of the aging population,
Mm-hmm.
it's not about that brick and mortar from a clinic and a hospital standpoint. A great deal of that is in the nursing home, is in the skilled nursing environment, and and when it comes to dementia, the non-skilled, the more memory care units and the like of that, the more we can stand up more of those dementia focused communities and the like, where we can provide services, the better access to, again, holistic care, we could probably really be able to build out in higher volumes. I'm a huge fan, and you should definitely get someone on here from a PACE program.
Yeah.
I have
Yep.
great friends who are running PACE programs, and just their holistic approach, their community based. It's about aging at home. It's about keeping someone in their comfort zone where their support mechanisms are, but bringing services to them.
Yeah.
That's the model that unfortunately I think we've ingrained a little too much into the medical model,
Mm-hmm.
that patients are expected to come to us because of all of our equipment and the like, but it's doing them a disservice.
I love how you brought up, let's challenge this concept of access and what does it really mean to be access. And then you also brought up a really important point about there are access challenges, of course, in rural communities that we absolutely need to address, but there's also access challenges in urban communities. I mean, it makes me
All of
think about when I was the Detroit health director, we were trying to expand access to reproductive health services, and we literally mapped out where the primary care offices were across the city. And there were like few, most neighborhoods did not actually have primary care close to someone so they could get to it easily. So I love what you're saying there. Now I'm gonna push a little bit. So I'm a
yeah,
practicing ER doc, right? So
yeah,
I'm the one, I can like diagnose, stabilize pretty much anything and everything. And so I believe that yes, absolutely, primary care is important, should be the cornerstone of healthcare in America. It is not.
mhm,
And we also need access to
without a doubt,
specialists. Tell us
without a
about
doubt.
kind of that I don't know if I should call it tension, but I am often in policy discussions where it's like primary care, those terrible specialists, they just want to bill,
Mhm.
bill, bill, and get rich. Which, if
Yeah.
you talk to any specialist, they're like, no, actually, I just want to do good care for people. How do we kind of um, have a discussion about the broad healthcare system and not pit primary care and specialty care
Yeah.
against each other?
Yeah. Um, I keep returning to this. It's about the business model, and honestly, even upstream of that, it's about the way that we're trained. If
Yeah.
we really built out more of, I talked about interprofessional workforce, we need
Yeah.
interspecialty workforce
Yep.
and care teams, where I would love to embed endocrinology into my practice and cardiology. So I have, multiple different PCP panels and an endocrinologist who's there for escalation as well as curbsiding, right? There's plenty of
Mm-hmm.
integrated health systems, the VA included, other commercial ones, where they have a really strong curbside sort of concept where you're there to help co-manage. You're there to,
Yep.
in every way, make sure you're managing escalation, but to support in a collaborative way. Collaborative care, particularly in the psychiatry
Mm-hmm.
integrated space, right, is a huge concept. And so we actually in Cityblock have built out our advanced behavioral health program
Yeah.
so that we can support our serious mental illness, our patients with serious mental illness in that sort of collaborative environment. So when it's about diagnosis, when it's about maintenance and kind of longitudinal treatment, primary care can definitely manage that. We can manage mild
Mm-hmm.
to moderate depression, anxiety. That's actually where the majority of that is actually
Mm-hmm.
diagnosed in the first
That's
place,
right.
right? But when it comes to schizophrenia and schizoaffective disorder and other psychoses, we're not as, updated, most likely in a lot of environments. We're not as comfortable. And so having psychiatry embedded in our practice where they're helping us, they're prescribing, but co-managing those patients even so that we can think about care plans jointly and we can really integrate beyond just co-location, beyond just having the same department in a health system.
Right.
How we actually work together, I think, would make a larger difference. And again, the business model, if their payment structure wasn't about an encounter based opportunity as well. You wouldn't see so many patients who are being jumped around to different
Right.
specialty visits, where instead I can make sure, as your primary care doc, I can reach out to your cardiologist, make sure we're all fine tuned there, reach out to
Yep.
endocrinology, reach out to pulmonology. And I've got plenty of that in Cityblock currently, where we have all of these specialists on board. Yes, we need their input, but it doesn't need to be at such a regular interval.
Right.
And it can be managed through the trusting and trusted primary care team.
Yeah, I love that. Just collaborative care, right? Being able
Mhm.
to reach out to a specialist when you need, but then coming back to this primary care
Yeah.
physician. So, transitioning, you've done so many things and do so many things for the community, but for the workforce as well, and mentoring. You do a
Yes.
lot of mentoring for the next generation of physicians in particular.
Yes, I do.
What do you think are the most important skills that future leaders in healthcare or public health need to have or need to be
Yeah.
developing?
I mean, obviously, having a strong clinical foundation is there, but I think there's a much broader education we could be providing our future workforce around healthcare, around not just the business of healthcare, but population health, quality, safety, communication, how we're actually engaging with the broader public, the broader community, so that we can manage epidemics as they come up and the
Yeah.
like. I think we need to think of the role, particularly when you're thinking about physician education, we need to think of the role in its broadest concept and
Mhm.
educate accordingly. So, what does leadership of a health system look like? What does, research, of course, look like? These are pieces that are a little bit closer to our current medical education, but there's so much around Medicaid, Medicare,
Mhm.
commercial and financing and the like that, our students and residents are coming out without any exposure to. Informatics, digital health, how to actually manage AI, how to think about vendors, how to integrate all of these services. Again, not something that students are exposed to.
Yeah.
So when I'm talking with my students, that's usually where I'm asking them to lean in and to take
Mhm.
on some of their own personal accountability of expanding really their exposure beyond just their clinical classroom setting.
Mhm.
So what other organizations, what other lectures, webinars, what other mentors can they talk to perhaps get these opportunities so that they can be at least exposed,
Right.
so
Right.
that, should they want to, specialized per se in these other kind of non medical spaces, that they at least know that that's an opportunity. I mean, you know me, I push a lot of students to think about correctional medicine and the
Yep.
VA and these other non-traditional spaces where I've practiced and where we need very strong clinicians, where you're at the front lines of health inequities. But the academic medical centers are pretty much training them in, to look like themselves, to
Right.
replace their current workforce. They're not thinking about the broader needs that local, if not national, communities need to be able to fill.
Right.
So when I'm mentoring students, it's about exposure, and letting them know that there are many more opportunities than, unfortunately, their limited education is currently providing them.
Yeah, I love that. Just getting exposure, just leaning in, learning from others. I think that's really, really important. And we need physician leaders who are great clinicians, of course, but
Yes,
also who understand the broader health care and health
exactly,
ecosystem. So love that.
exactly.
So final question for you, Dr. Matthews. What is one actionable tip, resource, piece of advice that you would recommend for colleagues, leaders in healthcare and public health who are really just, quite frankly, getting up every day and trying to improve health outcomes
Mm.
for everyone?
Oh, it's such a great question. One thing that they could do, um, I think get out of your specialty bubble
Hmm.
and attend either. I haven't done it myself, but American Medical Association, American, um, oh, what's your APHA? Yes, American
Yes,
Public Health
APHA.
Association, American College of Lifestyle Medicine. There are multiple. newer organizations that are not just focused on your specialty, but where you can learn a much broader, holistic approach to your practice and maybe get exposed to some of the opportunities that I've described today. I think we need to get out of our comfort zones, and I think physicians we have a sense of inertia. I think we typically find ourselves in a specialty where we're just gonna commit ourselves mentally and emotionally for the rest of our career. And I
Yeah.
think our positions deserve more. So even if that's going to be the rest of your practice, you're not going to, go off and gain expertise and lead some new informatics department or something. Even if you're staying in that space, I think the exposure piece is going to make you a better resource for your patients
Okay.
and understanding that AI and understanding all of these new digital options and understanding public health concerns and understanding lifestyle medicine, no matter what specialty, that there's a way that we can actually think about how patients treat themselves and not just write them off as wellness crazies or whatever. Like there's legitimate
Yeah.
data and focus that we can be providing that's eking into our traditional specialty academies, but there's a lot more. So think about your broader education outside of your traditional comfort zone.
Well, thank you so much, Dr. Matthews. It's always a pleasure to have a chat with you. You have so many experiences and just expertise to share with the world. And so thank you for being on our show.
Thank you so much. Congrats to Fab. I love that name again for this podcast, and I'm excited to be a part of the conversation.
Thank you.